All right, great. All right, well, we are at 8 o'clock, and welcome to all of to everyone, and hope you enjoyed our Frozen Lake discussion. Today we have our own Dr. Ann Misch giving us some literary references, one of my favorite trivia questions for my residents. So I'm very excited to hear about this. And to do the introduction is our own Dr. Dave Andes, our Division Chief of ID. David.
Dr. Schnapp, it's my pleasure to introduce Dr. Misch. A little bit of her background. So she completed her undergraduate degree at Oberlin, followed by her medical degree and residency at Johns Hopkins before moving across the country to complete infectious disease fellowship at the University of Washington, where thereafter she joined their faculty in the infectious disease division. We were fortunate to recruit Ann to UW in 2016. Ann has really broad infectious disease expertise. You may be familiar with her work on COVID therapeutics or transplant infectious disease, but as it relates to the topic she'll talk about today, she really is a national expert in the management of mycobacterial disease, serving as a consultant for the Center for Disease Control, and more locally, an expert for the state of Wisconsin. And at UW, co-founded a multidisciplinary clinic for the care of really the most complicated NTM cases in 2019. And I always learn so much when I hear Ann talk, and looking forward to this as well.
Okay, thank you, Dr. Andes, for that introduction, and thank you for the opportunity to speak today about nontuberculous mycobacterial disease, or NTM. I have no financial disclosures. Here is an outline of my talk. I'm going to begin by defining NTM and illustrating the spectrum of NTM disease. I'll then speak about the epidemiology, the incidence and prevalence of NTM, environmental sources of NTM, and a variety of risk factors. Next, I'm going to review the clinical presentation and diagnosis of NTM lung disease using the example of M. avium or MAC. And in the final section of the talk, I'll provide a broad overview of the prognosis and treatment of NTM lung disease. The talk's objectives are that by the end of this session, I hope that you can identify populations with a high prevalence of NTM lung disease, summarize non-demographic risk factors for NTM infection, outline diagnostic criteria for NTM lung disease, and discuss factors that affect prognosis in NTM lung disease. Before we go on, I just want to let you know that during the talk, I'll probably use the abbreviation NTM in place of nontuberculous mycobacterial disease for energy conservation purposes. So let's begin with a real case. This was a case seen on the Infectious Disease Consultation Service in October of 2020. Mr. P is a 53-year-old renal transplant recipient who presented with productive cough and dyspnea on exertion for a year and a half. His illness began in April of 2019 with a cough that became more productive over time, dyspnea and fatigue, with insidious onset. He reported that he kept a plastic pick and save shopping bag at his side throughout the day so that he could constantly spit into this bag. And by the end of the day, he had filled 1/4 of the bag with expectorated phlegm. He also reported a 25-pound weight loss over the past 3 months and a total weight loss of 42 pounds over the course of his illness. He had no fever, chills, or night sweats, and he had no personal or family history of tuberculosis. His past medical history was significant for FSGS, for which he underwent a renal transplant in 2013. He had been prescribed a TNF-alpha blocker at some point in the past for unclear reasons, and as a teenager, he had been diagnosed with asthma. Notable medications, including his immunosuppressive regimen of mycophenolate, tacrolimus, and prednisone. On social history, he reported that he had never smoked. He was born, raised, and still lived in Milwaukee. He had no outdoor hobbies or activities aside from mowing the lawn, and he identified as African American. On other review of systems at the bedside, he reported deep demoralization because of his weight loss. He told us that I looked in the mirror and saw myself just disappearing. A chest CT was obtained and showed tree and bud nodules in the right upper lobe, as shown here in the picture in the left upper corner. Bronchiectasis was also seen and described in the bilateral lower lobes, outlined in red in the image on the right. He underwent bronchoscopy with acid-fast organisms seen on smear, and an interferon gamma release assay was negative. So this case raised several questions for our multi-person team. First, the medical student wanted to know which NTM was the most likely cause of Mr. P's lung infection, and which risk factors led to his acquisition of NTM. Mycobacterial lung disease has long been described as a disease that predominantly affects persons of European descent. I wanted to know if this is still true. Should Mr. P be treated? And if so, what should we tell him about his prognosis with or without treatment? So let's begin by defining nontuberculous mycobacteria, or NTM. First, these are a genus of bacteria, and they include all mycobacteria aside from the members of MTB complex and 2 species that cause leprosy. They are ubiquitous in the natural and the built environment and can be found in swimming pools, shower heads, salt water, fresh water, brackish water, municipal water supplies, swimming pools, and elsewhere. They also can be found in association with plants, birds, fish, and other animals. To date, 200 species have been discovered, of which only about 40 cause disease in people. This table shows the 6 most frequent NTM pathogens in North America. The bottom half of the table, which is in yellow, shows rapidly growing NTM, which by definition grow within 7 days on subculture. The top half of the table, in green, shows slow-growing mycobacteria, which take longer to grow in subculture. Among the slow-growing mycobacterial species, Mycobacterium avium complex is the most frequently encountered. This group, known as MAC, actually contains 12 species, including Mycobacterium avium, M. intracellulare, and M. chimera. MAC usually causes lung disease, but can occasionally cause lymphadenitis, usually in children. In persons living with HIV and AIDS, it can present as fever of unknown origin with pancytopenia and lymphadenopathy. MAC can also cause disseminated disease in patients with inherited mutations in the IL-12 interferon gamma signaling pathway. M. kansasi causes a tuberculosis-like lung infection, often with cavities, and Mycobacterium marinum is famous as a cause of fish tank granuloma or swimming pool granuloma. Among the rapidly growing mycobacteria on the bottom half of the table, M. abscessus is the most frequent and can cause lung disease or skin disease. And it's regarded as an emerging pathogen, second only to MAC as a cause of NTM lung disease. M. cheloni and M. fortuitum are 2 other rapidly growing NTM species that mostly cause skin and soft tissue infection. M. fortuitum can cause lung infection in rare instances, but usually in patients with chronic aspiration. Now, the vast majority of NTM disease, about 80%, involves the lung. But the second most frequent type of infection is skin and soft tissue, which accounts for about 12% of all presentations. Disseminated disease and lymphadenitis represent about 5% of infections. It's important that you're aware of them. Because the rest of this talk is going to focus on NTM lung disease, I want to spend a minute talking about NTM infection outside the lung. Skin and soft tissue infections can often be seen after cosmetic or surgical procedures, as seen here in the images on the right. This patient underwent a Brazilian butt lift in Florida that was complicated by a Mycobacterium abscessus infection. And like many patients with NTM disease, his diagnosis was delayed because physicians did not suspect mycobacterial infection and failed to send appropriate cultures. The CT scan shows multiple intramuscular and subcutaneous abscesses in the gluteus. And on the far right, you can see the extent of debridement that was required to control this infection in conjunction with antibiotic therapy. There are many reports of NTM skin and soft tissue infection by now in the context of cosmetic tourism to countries such as Brazil and the Dominican Republic. Community outbreaks of NTM infection due to M. fortuitum and M. chelonae have also been reported in association with tattoo parlors and nail salons. And shown here in the bottom right is an image from a patient from Seattle who went to a tattoo parlor and developed a skin and soft tissue infection as a result of the tattoo ink being contaminated with Mycobacterium chelonae. Ultimately, this outbreak involved 19 people. Lymphadenitis also occurs in children and is generally due to Mycobacterium avium complex, or MAC, as shown here. This child has preauricular and posterior auricular lymph node involvement with sinus tracts draining to the skin. Other important but uncommon presentations of NTM lung disease include disseminated infection, which is always seen in immunocompromised hosts. Examples of this include disseminated MAC in persons living with HIV, and in the image on the right-hand side of the slide, disseminated Mycobacterium genevense in an infant with Mendelian mutation in the interferon gamma receptor 1. Infections of the bones, joints, and tendons can also occur, and examples of this include the patient in the upper right-hand corner with spinal osteomyelitis and discitis due to Mycobacterium zenobi, and a second patient in the left corner with septic arthritis and nodular skin lesions. The eye can also be involved in NTM infections following trauma or cataract or LASIK surgery, as shown here. The near image shows a patient with Mycobacterium fortuitum keratitis, producing a classic cracked windshield appearance. And on the far right are retinal lesions caused by disseminated Mycobacterium chimera in a patient who had cardiac surgery involving a contaminated heater-cool unit. So now that I've given you an overview of NTM infection, let's turn to the epidemiology of NTM. So how common are these infections? In a study published in 2020, Kevin Winthrop and colleagues at the University of Oregon described the incidence and prevalence of NTM lung disease in the United States between 2008 and 2015. And to do this, they utilized a national managed care claims database that contains 75 million members. Along the y-axis of this graph is NTM lung disease prevalence per 100,000 persons. Along the x-axis are the years of the study. Persons over age 65 in this database had the highest rate of NTM disease. Among Medicare patients, prevalence was also high and increased more than twofold over the course of the same time period. Women had higher disease rates than men, but disease in both groups, as well as overall prevalence, increased more than 7% each year. For comparison, on the right-hand side of the graph are current estimates of the prevalence of cystic fibrosis, which you have heard about recently at a Grand Rounds presentation, and systemic sclerosis. If we compare the prevalence of NTM lung disease in the United States, shown in the blue bars, between 2008 and 2015, to the rates of tuberculosis, shown in the orange bars over the same time period, we can clearly see that the trends are in opposite directions, with tuberculosis prevalence falling as NTM rates are rising. If we then look at these trends over a longer time period, the pattern emerges even more clearly. Since the early 1980s, there's been a dramatic fall in tuberculosis rates, while NTM prevalence has markedly risen. Very few studies have investigated NTM disease within different ethnic subgroups in the United States. But here's what we've been taught about NTM lung disease and ethnicity. Wallace, in a paper published in 1989, wrote, "Almost all patients are over 50 years of age and the majority are white." Griffith, describing a group of 154 patients seen at the University of Texas in 1993, described the majority of the cohort as white. And he concluded that NTM lung disease is a disease that occurs with greater frequency in white people. Prince provided one of the first descriptions of NTM infection occurring in elderly white women without structural lung disease, i.e. the Lady Windermere syndrome. In doing so, he contrasted his findings to the previous, the traditionally accepted high-risk group, writing, "The typical patient with pulmonary disease caused by MAC has been described as an elderly white man with underlying chronic lung disease." And in 2007, the IDSA ATS guidelines stated MAC lung disease also presents predominantly in postmenopausal, non-smoking white females. MAC lung disease in this population is sometimes labeled the Lady Windermere syndrome. This study by Gemini and colleagues is the only one I'm aware of that has actually looked at the risk of NTM disease in different ethnicities using a large cohort. These authors analyzed data from 2.3 million Medicare Part B beneficiaries, including 2,500 patients with NTM lung disease. They found that the overall rate of NTM prevalence in Blacks was half that in whites, as shown with the dotted lines in the figure above. However, if we look at the data more closely, we see that the rate of NTM infections in Black men, which is shown in gray, is very similar to that in white men in the left-hand columns, also shown in gray, and that it is really Black women, shown in the white bars, that are driving the lower rate of disease in Blacks as a whole. This could suggest that Black women are more resistant to NTM infection, or that NTM infection is underdiagnosed in Black women. Another very interesting finding in this study was that the rates of NTM disease in Asians and Pacific Islanders was far higher than that in any other ethnic group. For example, rates in male Asian Pacific Islanders are more than 2.5 times those seen in white men. High rates of NTM were also seen in female Asian Pacific Islanders as compared to white women, white men, Blacks, and Hispanics. So it turns out that Wisconsin is one of 9 states with the highest prevalence of NTM in the United States. And in addition, Wisconsin is one of only 7 states that mandates laboratory reporting of all NTM and has done so since the 1970s. Microbiology labs through the state of Wisconsin submit data on these NTM isolates to a state electronic database. We wanted to know whether the risk of NTM infection varied across the different ethnic groups that live in Wisconsin. To do this, we analyzed a data set containing nearly 7,000 Wisconsin residents with NTM infection and 9,000 NTM isolates reported into the state electronic database. This table shows the demographic features of Wisconsin individuals with NTM infection. First, as expected, the median age of people in this database was approximately 66, similar to that seen in other studies. The prevalence of NTM was higher in women than in men, as expected. In whites in Wisconsin, the annual incidence of NTM infection we found was 12.2 per 100,000, compared to 28 per 100,000 in Blacks and 31 per 100,000 in Asians. And intriguingly, similar to the data I just showed you in the Medicare beneficiaries, we found the highest rates of NTM infection among Pacific Islanders, who had an average annual incidence of 82 per 100,000 over this study period. We also wanted to know whether social and economic status has any association with NTM infection, which, for example, has been shown for tuberculosis. The Area Deprivation Index, or ADI, is a validated measure of social economic disadvantage. Data on the ADI score linked to specific street addresses are available online through the Neighborhood Atlas, which is the creation of Dr. Amy Kind, a member of our department. On the y-axis of this graph is the percentage of total NTM infection, and along the x-axis is the ADI decile. By definition, each decile represents 1/10 of the population, with decile 1 being the least disadvantaged and decile 10 being the most disadvantaged. If NTM infection were equally distributed across all social and economic categories or deciles, each decile in this graph would be at 10%, as shown in the dotted bar line. However, what we actually found was that both total and respiratory NTM infection, which are depicted in the dark blue and medium blue bars respectively, were significantly more frequent in the 10th or most disadvantaged decile. Altogether, our data suggests that NTM disease is highly prevalent among disadvantaged and ethnic minority populations in Wisconsin, and that we need to do more to understand and remediate risk factors for disease in these groups. So I've shown you that NTM prevalence is increasing and also that NTM occurs more frequently in certain ethnic groups. But where is it that people are getting exposed to NTM? Well, it turns out that we live in very intimate proximity to Mycobacteria, Unlike other bacteria, Mycobacteria are relatively resistant to chlorine, which leads to their being enriched in municipal water supplies, as other bacteria are removed by chlorination. Household water supply in particular has been implicated in the acquisition of infection with NTM. Showerheads, for example, are moist, warm, and dark environments that favor the formation of biofilm, and they're frequently bathed in nutrients and reseeded with organisms to replace those washed away by the flow of water. When they are turned on, showerheads aerosolize organisms within biofilm and thus allow direct and frequent exposure to NTM. In a study called the Showerhead Microbiome Project, Giebert and colleagues collect over 600 showerhead biofilm samples across the United States by recruiting citizen scientists. Using molecular methods, they found that the genus Mycobacterium was the most abundant group in showerhead biofilm and represented about 15% of all organisms recovered. They also found that Mycobacteria were 2 times more abundant in households supplied with municipal water compared to those supplied with well water. And this is probably because municipal water had a 15-fold higher chlorine content. And in showerhead biofilms from municipal water supplied households, there was a greater concentration of pathogenic mycobacterial species, such as Mem avium and Mycobacterium abscessus. Here are the maps which show the relative frequency of 2 pathogenic species of NTM, MAC in the top and M. abscessus in the bottom, across 23 different geographic clusters in this study. Interestingly, greater frequencies of M. avium were recovered in showerhead biofilm samples from states which also have a high prevalence of NTM disease. For example, California, Hawaii, Florida, and Wisconsin. The authors then correlated the frequency of pathogenic NTM with the distribution of NTM disease across the United States. On the y-axis is the prevalence of NTM disease among Medicare beneficiaries expressed per 100,000 persons. On the x-axis is the combined frequency of M. avium and M. abscessus in showerhead biofilm samples. The colored circles represent different states. You can see that among states with lower rates of recovery of pathogenic NTM from showerheads, such as Massachusetts, there is a lower prevalence of NTM disease. In contrast, in states with a higher frequency of NTM in showerhead biofilms, such as Wisconsin, there are higher rates of NTM disease. Overall, there was a 70% correlation between showerhead frequency of pathogenic NTM and NTM disease prevalence, which is highly significant. And the authors concluded that regions in the United States where NTM lung infection is most common are the same regions where pathogenic mycobacteria are prevalent in showerheads. Correlation, however, is not causation, and to investigate whether the species and strains of NTM found in NTM patients are the same, found in households are the same as those found in NTM patients, Falkingham sampled the household water systems of 31 NTM patients. About 60% of the households yielded NTM, and in 46% of these, the same NTM species was found in the household and in samples collected from the patient. And in 41% of these cases, the isolates were identical by DNA fingerprinting, as shown on the right-hand side of the slide. Other investigators have shown that the species and strains of NTM found in the environment of patients with NTM lung disease are identical to their clinical isolates. So to summarize, NTM are enriched in municipal water as a result of chlorination, and they're then delivered directly to us in our households when we take a shower or a bath, and may then go on to cause disease. But if NTM exposure is so universal, then why don't all of us have NTM disease? To answer this, we have to consider 2 other variables in the infectious disease equation: the pathogen, which may possess virulence factors that enable the survival and growth of mycobacteria, and the host, who may have resistance or vulnerability to disease depending on genetic traits, immune suppression, or other comorbidities. The first thing that we have to acknowledge is that not all NTM are created equal. For example, this picture depicts increasing pathogenicity or the likelihood of disease occurring each time an NTM species is recovered from respiratory sampling. On the left-hand side of the scale are 2 rapidly growing NTMs, M. fortuitum and M. chelonii. These species rarely cause lung disease, although they are important causes of skin and soft tissue infection. M. avium and M. abscessus, by contrast, are clinically significant more than 50% of the time. And finally, M. kansasi is similar to Mycobacterium tuberculosis, which is presumed to cause disease whenever it is recovered. Turning to the host, for most infections, susceptibility is determined by a polygenic pattern of inheritance. That is, many genes each contribute a small amount to the risk of any particular pathogen. For most people, susceptibility to NTM is determined by this type of polygenic inheritance. That is, NTM disease is a result of the additive effect of multiple gene variants that each contribute a small amount to overall susceptibility. In rare individuals, the opposite pattern of inheritance can occur as a result of highly penetrant Mendelian mutations. In these people, a single gene may cause extreme susceptibility to many pathogens, one example being SCIDs. More recently, a new category of primary immunodeficiency disorders has been described, in which one gene or gene loci can confer risk to a restricted number of pathogens. An example of this newer type of primary immunodeficiency is Mendelian susceptibility to mycobacterial disease, or MSMD. MSMD is caused by defects in the interferon gamma IL-12 signaling pathway. The interferon gamma IL-12 signaling pathway, it turns out, is critical to control of mycobacterial, but redundant for control to other pathogens. On the right-hand side of this slide is a diagram of this pathway. The large green cell at the bottom of the diagram is a macrophage, which is the host cell of mycobacteria. When the pulmonary macrophage becomes infected with mycobacteria, an innate immune response is initiated, which leads to the production of IL-12, a pro-inflammatory cytokine. IL-12 engages the IL-12 receptor on T cells, stimulating the secretion of interferon gamma by T cells. Interferon gamma, in turn, interacts with the interferon gamma receptor on the macrophage, activating STAT1 and leading to the elimination of intracellular mycobacteria by nitric oxide and other effectors. To date, 25 mutations in 17 different genes in this pathway have been identified. Almost all individuals with MSMD present with disseminated disease in infancy or childhood. They can also be susceptible to some fungal and viral infections. So one exception to the rule that individuals with MSMD present in childhood is GATA2 deficiency. This disorder is caused by a heterozygous mutation in the gene encoding the transcription factor GATA2. Patients with GATA2 deficiency can present in adolescence or adulthood with disseminated NTM. They usually have cytopenias and can have infections with human papillomavirus or Epstein-Barr virus as well. In contrast to these genetic disorders, antibodies to interferon gamma can cause acquired susceptibility to NTM. In this disorder, individuals have high titer antibodies that completely block interferon gamma activation. These patients are usually Asian females presenting in adulthood and may also be susceptible to other intracellular pathogens. So you might ask whether all patients with NTM infection should be worked up for MSMD. The answer is yes, if they present with disseminated disease, but no in general for pulmonary disease. Unless the pulmonary disease is recurrent, persistent, or severe, or they're infected with an NTM species that's usually non-virulent. They present without pre-existing structural lung disease, and they have NTM lung disease at a young age. Other systemic immune defects are also associated with the risk of pulmonary NTM, but not disseminated NTM. Some of these defects are genetic. For example, patients with STAT3 deficiency, which causes hyper IgE or Job syndrome, have a high prevalence of NTM lung disease. And the Lady Windermere syndrome, which refers to elderly white women with right middle lobe or lingular NTM infections, probably determined by multiple gene variants. Immunosuppressive drug therapy also increases the risk of NTM. In addition, a number of conditions are associated with local immune defects at the level of the respiratory epithelium or pulmonary macrophage and increased NTM risk. Structural lung disease due to COPD or asthma and other lung disorders is frequently seen in patients with NTM infection. And NTM lung disease is highly prevalent in patients with cystic fibrosis and primary ciliary dyskinesia. So diagnostic testing for these disorders is reasonable in some NTM patients. Let's now discuss some of the clinical features and diagnostic criteria for NTM lung disease using the example of MAC. So as it turns out, the majority of NTM lung infection is caused by Mycobacterium avium complex or MAC. The clinical features of MAC are quite well described. Patients normally present with local complaints, most often cough and productive sputum and dyspnea. And they may also have systemic complaints, which can include fever, fatigue, and weight loss. Most patients have at least one symptom. There are essentially two major phenotypes of MAC lung disease. The first is nodular bronchiectatic type, or NB-MAC. The typical patient is a postmenopausal white female, often with a characteristic physical build, that is to say slender, sometimes with pectus excavatum or scoliosis. Patients with NB-MAC usually have a negative sputum AFB smear, indicating a lower burden of disease. These patients are frequently heterozygous for single CFTR gene mutations. Prolonged cough with fatigue and weight loss are typical, and 50% of patients with NB-MAC will not progress, and up to a third may spontaneously convert their sputum AFB cultures to negative without having any treatment. On chest CT, the classic finding is bronchiectasis with nodules, often described as tree and bud in the right middle lobe and lingula. So here's an example of classic tree and bud nodules seen in this patient in the right upper lobe, indicated by the yellow arrow. And to the right of this is a cartoon illustration of a tree with budding leaves. On the far right-hand image is another example of nodules that can be seen in patients with this type of MAC lung disease. The other major type of NTM lung disease is fibrocavitary MAC. And these patients are usually male, over age 50, with structural lung disease due to COPD or other disorders. Generally, their acid-fast stains on the sputum are positive. Their clinical course is progressive, and they may have systemic symptoms and signs of inflammation. They have worse outcomes and lower survival than patients with NB-MAC. On chest imaging, cavitary lesions are often seen and can even be seen on chest X-ray, and these classically involve the upper lobes, as shown here. The 2020 ATS-IDSA NTM guidelines outline 3 diagnostic criteria for NTM lung disease. To meet these, patients must have clinical signs of disease, as I just reviewed, radiographic findings suggestive of NTM, which I just showed you, and positive cultures from 2 sputum samples, 1 BAL or biopsy tissue. I would now like to describe in sort of a broad overview prognosis and treatment of NTM lung disease. The intent of this section of the talk is to give you an overview of the natural history of MAC and a few important principles of MAC therapy. So since over half patients who meet diagnostic criteria will progress within 3 to 5 years, the 2020 NTM guidelines suggest starting treatment in these patients rather than pursuing a strategy of so-called watchful waiting. However, no randomized controlled trials have examined whether treatment improves survival or quality of life. Given this lack of data from randomized clinical trials, one reasonable approach adopted by most NTM experts is to consider several factors when weighing the decision to start therapy. Patient factors such as age, male gender, the presence of comorbidities, weight loss, or systemic symptoms should weigh in favor of starting therapy. Labs indicating inflammation or imaging showing cavities should also prompt the initiation of therapy. Finally, patients with a higher bacterial burden, more virulent NTM species, or disease outside the lung should probably be treated. The recommendations to start treatment in patients that meet diagnostic criteria are basically based from observational data, similar to what you see on this slide. In this study, Wang and colleagues followed 500 Korean patients with MAC lung disease who were not immediately started on therapy. They found that patients with a higher BMI were significantly less likely to progress to needing treatment, and conversely, patients with a lower BMI were more likely to progress. Patients with systemic symptoms such as fever, fatigue, or weight loss at the time of diagnosis were also more likely to progress. In addition, patients with positive AFB smears or a fibrocavitary pattern of disease and greater extent of lung involvement were also more likely to progress. For patients who start on therapy, a 3-drug regimen containing a macrolide, rifampin, and ethambutol given 3 times weekly is recommended. For patients with fibrocavitary lung disease or nodular bronchiectasis with cavities, a typical regimen would include 4 drugs. 3 of these drugs are the same oral drugs as used in NB disease, but are given daily. In addition, an intravenous aminoglycoside is generally given 3 times a week. Treatment for both types of NTM lung disease is continued for 12 months beyond sputum conversion. Once therapy is started, sputum cultures are typically obtained monthly to determine when cultures convert to negative. Patients whose AFB sputum cultures convert to negative by month 6 of therapy are considered to have responded to drug treatment, which is then continued for an additional 12 months. Overall treatment success in these patients is approximately 60%. And this number is less than 100% because approximately a third of patients with NB MAC and 20% of those with fibrocavitary MAC end up redeveloping infection within 12 months of completing therapy. Patients who do not convert their sputum cultures to negative within 6 months of initiating therapy are considered to have refractory MAC. The best studied options for refractory MAC is amikacin liposomal inhalation suspension, or ALIS. ALIS is added to baseline therapy of 3 drugs. In the extension phase of the CONVERT trial, adding ALIS to 3-drug guideline-based therapy resulted in sputum conversion in 80% of trial participants. Other options, including enhancing the baseline regimen by adding additional drugs such as clofazimine, linezolid, bedaquiline, or IV aminoglycosides. For some patients, surgical resection is indicated and may result in cure or sustained culture conversion. So macrolides are very critical to the successful treatment of MAC and many other NTM, but macrolide resistance can occur. Fortunately, this is rare in patients who are treated appropriately. However, resistance is likely to occur in 20% of patients treated with a macrolide alone. And studies have also shown that having a thiambutal in the regimen is required to protect the macrolide against emerging resistance. Substituting a fluoroquinolone for a thiambutal also increases the likelihood of macrolide resistance. Somewhat shockingly, a survey published in 2014 showed that only 13% of MAC patients were being treated with guideline-based therapy. Treatment options for macrolide resistance are limited, but are similar to those for refractory MAC and include clofazimine, bedaquiline, linezolid, IV amikacin, and ALIS. As this slide shows, treatment of patients who have macrolide susceptible MAC, even if they have cavitary disease, is effective 50 to 80% of the time. In contrast, the prognosis for patients with macrolide resistant MAC is much worse. With surgery and long courses of IV aminoglycosides, treatment success can approach that seen in patients with macrolide susceptible MAC. However, these regimens are toxic and they're very hard to complete. So returning to our patient, Mr. P, the sputum cultures ended up growing MAC, which is macrolide susceptible. He was started on daily therapy with azithromycin, ethambutol, and clofazimine. Rifampin was not given because of drug-drug interactions with mycophenolate. Within 6 months, his sputum cultures had converted to negative. He stopped coughing and regained weight. And a follow-up CT, 10 months into therapy, showed marked improvement. In April of 2022, Mr. P will have completed 18 months of therapy. So I hope that during this talk, I've been able to show you that NTM incidence and prevalence are rising, that household water and showering is an important source of NTM exposure, that NTM infections are prevalent in Asians and Pacific Islanders, and maybe also in Blacks, more so than in whites, and that NTM lung disease, which is most often due to MAC, is the most common presentation of NTM infection. Risk factors for NTM lung infection include structural lung disease, multiple risk genes, and immune suppression. Patients who meet ATS-IDSA criteria for NTM lung disease should probably be treated. Please seek expert guidance. We are happy to help. Men, older individuals, people with cavities, patients with low BMI, immunosuppression, or macrolide resistance have worse prognosis. And finally, we really need future research to evaluate outcomes of therapy for NTM lung disease and to identify the mechanisms of enhanced susceptibility in certain ethnic groups. I'd like to acknowledge members of the NTM research group especially Brian Bonasek, a pediatric ID fellow who has helped analyze the NTM data in Wisconsin, Daniel Gooseland, Kevin Hash, and Susan Gibbons-Bergener, the Wisconsin State epidemiologist, as well as Julie Tens-Kirsten, the former director of the state TB program. Also, all my colleagues in NTM clinic who are listed here, and my mentor, who's Dr. Nastia Saftar. Thank you.
Okay, great, thank you. Okay, so Anne, you did not address the most important question.
Yes.
Why is it called Lady Windermere syndrome? What's the background for that?
So I didn't talk about the play. Is that what you mean?
Yes, and,
Yeah.
and the
I didn't
theory
have
behind
time.
it.
Yeah. So there was a paper written by Reich and colleagues that so this is an unfortunate eponym. And the reason I think it hasn't been withdrawn is that Lady Windermere is not a Nazi and she's a fictional character in a play.
By
Lady
Oscar
Windermere,
Wilde.
yes, this is a play by Oscar Wilde called Lady Windermere's Fan, which you can actually look up on YouTube. And Lady Windermere has these antique puritanical Victorian manners that sort of lead to the situation in which she would not cough in public. So the idea there being that elderly women with a similar fastidious behavior would not cough, and this cough suppression would predispose them to bronchiectasis. I didn't address this because really the what we use Lady Windermere now is as a description of the body morphotype or the physical architecture of patients who are slender and postmenopausal and white, because nobody really thinks that cough suppression is why you have NTM lung infection. So it's really sort of an unfortunate eponym, but most of us aren't cultured enough to know what it means. And so it doesn't really matter.
But it will for the residents and fellows who I will pimp them on rounds and ask them about it. So
you can look up the play on YouTube.
Yeah, Oscar Wilde, Lady Windermere's Fan.
Yep.
Thank you. So there are several questions in terms of once you diagnose NTM in a patient, given the high prevalence of culture positive shower heads, et cetera, what are the recommendations in terms of, making any changes in the household, et cetera?
So there aren't any. It's not formally addressed. I sometimes, I actually don't address the shower. There's not much you can do. So I suppose you could put a filter on your shower, but then I think the filter can itself become encumbered with biofilm. So there's not much you can do. You could move houses. I had a patient of mine actually move her house. I didn't suggest it, but she did that on her own. I do tell patients to kind of cut down on the gardening, and we of course tell people not to use their hot tub. But and the other non-pharmacologic aspects of NTM management, which I didn't have time to get into, are involve secretion management, which is critically important, but actually not shown in studies to matter, unlike how it matters in CF. And management of GERD, which is associated with NTM, but it's not clear if taking proton pump inhibitors is facilitative to mycobacterial persistence or helpful in the treatment of MAC.
Yeah. So basically, no specific recommendations. Your patient can change their shower head if they desire, but not clear if that's.
I don't tell them too much about the shower head because I think it's dispiriting.
Okay. So the genetic susceptibility to NTM disease, does that also increase your risk of MTB disease?
Yeah, the reason it does, but there's less MTB. So generally in the United States, people will present with NTM infection or salmonellosis. And if these patients were to present in a country with a higher endemicity of TB, they would present perhaps with disseminated TB. But yes, if they're foreign born and happen to have this, they could present with MTB. Absolutely.
Then a comment from our Dr. Denlinger. The expected radiographic pattern for inhalation of steam is hypersensitivity, not tree and bud. Mm-hmm. And GERD-related nocturnal aspiration can cause tree and bud. Sinus rinsing with shower water is a common practice that can be avoided. Okay. And a comment from Dr. Lucy, which was also my experience as well. Well, basically disseminated MAC infection in patients with AIDS with and MAC infection of the liver as a premorbid condition. Those back in the early days of AIDS, when we saw a lot more disseminated MAC, we're not prophylacting. We're not giving prophylaxis for MAC, which we do now with appropriate patients.
Yeah, that's a presentation. I'm not sure what the question is. I did mention it.
It's more of a comment.
Yep.
But it has historical significance.
Yes, it
does. Can you have person-to-person transmission?
Yeah, that's a good question. So the only situation in which that's been described that I'm aware of is in CF clinics. There has been what we think is person-to-person transmission of Mycobacterium abscessus, and that is the only NTM for which I think that applies.
Great. And then in terms of environmental risk factors, you mentioned water, mowing grass, other environmental risk factors that you commonly see?
I mean, I think, I don't think mowing grass is particularly a risk factor. I think people who garden or, they sort of have their nose in the dirt, may be at risk. And people, if they're very avid gardeners, a lot of the patients in our clinic, one of them just described her dyspnea as she was moving from one flower bed to the other. So in those patients, I sort of say, can you kind of knock back on the gardening for a little bit?
Does continued tobacco use impact treatment success or failure?
Yeah, that's a really good question. I actually don't know the answer to that. It's someone, Lauren may know better.
Ask him a question.
Lauren asked. We don't, it isn't actually, I don't know that we know the answer. I mean, we know that smoking affects the pulmonary alveolar macrophage and its sort of functionality, affects respiratory epithelium. So I'm sure it's not beneficial, but I'll have to get back to you on that.
Yeah. Just a shout out from Caitlin Pepperell that they have documented person-to-person transmission of M. abscessus.
Yeah, right.
Yep, as commented. I wanted to get back to your comment about expert advice. I do find, even as a pulmonologist, getting an isolate, getting a culture positive for NTM, I hate it, and never know, always challenged to treat, not to treat, what to treat with. What's your advice for primary care physicians who are, get a sputum that comes back positive? Should all of those patients at least get an initial consult with an expert?
Yeah. So one sputum, they don't meet diagnostic criteria, right? But one sputum with suggestive radiology means that they probably are going to meet diagnostic criteria. I think it's good to call us up and chat. Because I think that the big difference between the 2007 and the 2020 guidelines shows is that they flipped from saying, watchful waiting is sort of fine, to saying that we really think you should initiate treatment, but we're not quite sure which patients will benefit from it. That's essentially what the guidelines say, which is why we all stay up late at night reading guidelines, because the plot lines are so dramatic. But at any rate, I think we should. I think it's good to discuss, because I've seen most what happens is an error on the side of not starting treatment in patients who are going to progress. So I'd rather have too many questions than too few.
And in terms of infection control, when if you have an inpatient who gets a positive AFB smear and you suspect NTM.
Well, I mean, right. So in transplant patients, for example, we do get a lot of AFB cultures, right? And some of them maybe we sort of are somewhat forced by the sort of not unimportant public health concerns about tuberculosis to at least get another sample. If it's a BAL, so the State Department will do a rapid probe test. And so they can tell you very quickly if it's, so in a respiratory sample, if it's AF positive, AFB positive, you'll know very quickly within a few hours or in the next day whether it's pro positive for TB. And so that, that quickly, you can quickly stop isolation. If you have a BAL, for which the MTB probe is negative for MTB or MAC. I mean, MAC is, you don't need to isolate. So I think you just keep isolation in place until you either hear about that, that's basically what you should do.
Yeah, great. Any association with NTM and cannabis?
I don't know.
Okay.
I don't know.
And a comment just on my comment earlier, and I acknowledge that the lower rate of MAC that we currently see in HIV is primarily related to the use of antiretrovirals.
Yeah. So MAC.
Yeah.
Correct. So the patient who has HIV who develops MAC is generally not on antiretroviral therapy with a CD4 count less than 50. And we can see it. There are people like that still that present, but we just don't see it as much.
Yeah. And do you think clofazimine will ever become more available?
Maybe. It's hard to use it. Because it's not available, but it's also, it can be quite toxic, although it's not usually in practice as toxic as the package insert, which leads you to believe. Perhaps I would be happy to see more of it, but I don't just want anybody giving it because it really can prolong the QT. You have to be very careful.
Yeah, and following up on just that in theme in general, what is the tolerance of the therapeutic regimen? Because I've seen issues with that.
So this is one of the major reasons to involve experts in the treatment of NTM. It's difficult. So a lot of these older patients who are 75 or 67 or whatever, some of them are really frail. I've seen some patients have a reaction to every single thing. Other patients sort of do well. What I've actually found is that the canonical drug toxicities that we worry about and we tell patients about, like rifampin-induced hepatitis or azithromycin and deafness or thiambutal and eye toxicity, that happens. But what happens more is just sort of more prosaic intolerances or these strange, inner sort of reactions on the part of individual patients. So it's difficult. I would say that most of my patients actually are able to stay on their regimen. And if they don't, I very, very slowly back off and just start, with one or two drugs, usually 2 drugs, very carefully. And in that setting, you can use inhaled amikacin, which is has a little bit less systemic toxicity, but has its own problems. And
when you start a 3-drug regimen, do you continue that for the full course, or do you ever?
Yes. Yeah, it's unlike TB. So you do 3 drugs for the entire time.
Okay.
Immunoglycoside, though, doesn't usually manage to last for 12 months.
And then, is there any particular immunosuppression regimen that predisposes one to NTM?
Yeah, so I think the worst offenders are steroids and TNF alpha blockers. And this is probably why we see a whole lot of NTM in patients who have rheumatoid arthritis and also Sjogren's. So I didn't have time to get into that, but the TNF blockers and steroids in particular. And then there are probably some JAK kinase inhibitors that might predispose.
And what is the, how do you consider a history of NTM when you are evaluating a patient for transplant?
Whether or not it makes them not a candidate for transplant, is that what you're getting at?
Or do you need to, treat them during their include treatments rather than prophylaxis?
Correct. So if it's a lung transplant patient that you're asking about, we can start with that first. So for lung transplant patients, so you can't use the rifamycin after transplant. It's inconvenient. You have to remove it because it interacts with mycophenolate. So you can use a different drug called clofazimine. In general, NTM infection is not a contraindication to lung or other transplantation. In fact, getting the lung out removes a lot of the burden of disease. And then we treat for 3 to 6 months after transplant with a regimen that omits the rifamycin. So in the case of Mr. P, he got clofazimine. For non-lung transplant patients, it's also not a contraindication. The one situation where it probably is, at least relatively, is macrolide resistant MAC. That's quite difficult to treat. You do want to sort of make sure the patient can tolerate a regimen before they get transplanted. Otherwise, they really shouldn't. And you want patients to be on treatment for, I would say, at least 3 to 6 months before they get a transplant. Generally, what I found is our transplant teams would rather have them complete their treatment for MAC, but I personally don't think that's essential.
Great, thank you. All right, well, we are just about at the end of the hour, so I really want to thank you for a wonderful overview and presentation of NTM. It is a challenging challenging diagnosis and treatment regimen. It is a continuously evolving story that is increasingly important. I think we all have seen the increase in prevalence of disease, just anecdotally supported by the epidemiology. So thank you so much, and everybody enjoy the rest of the day and the weekend. Take care.
Thank you.